Hi, this is Michael Altos, and we are continuing with our discussion on the coagulation system, and this is part 2. So now we're going to talk about warfarin, which is Coumadin. This is an oral medication, and patients take it for a variety of reasons, including prevention and treatment of deep vein thromboses, pulmonary embolus, and other thrombus that can occur throughout the body. Patients who have atrial fibrillation, prosthetic heart valves, and other hypercoagulable disorders are all at risk for developing blood clots, and warfarin would be used to prevent or treat those complications as well. The way warfarin works is by inhibiting an enzyme called vitamin K epoxide reductase. This enzyme basically is involved in the synthesis of certain coagulation factors. Specifically, those factors are 2, 7, 9, and 10. And so patients who get warfarin become deficient in those 4 factors. They also become deficient in protein C and protein S, which are actually anticoagulants, and we'll talk about that in just a moment. Coumadin does not have any effect on platelet activity. It works solely on the coagulation system. And actually, the first factors that are inhibited are protein C and protein S. And since those substances are not coagulation factors, they're actually anticoagulation factors. So patients can become hypercoagulable when warfarin is first started. And for that reason, patients are usually started on heparin, and once they become therapeutic in their anticoagulation, then warfarin is added, and then when warfarin is therapeutic, the heparin can be removed. Warfarin has a slow onset of action. Nothing happens for at least 8 to 12 hours, but the peak effect probably occurs in the 2 to 3 day range with a half-life of 40 hours. The effect of Coumadin continues for about 2 to 5 days after the drug is stopped, and we need to consider that when we schedule surgery, since most surgeries are only done after the patient has been weaned from their warfarin. The most common side effects, of course, are bleeding, and a lot of patients will present with bleeding in the brain, and if you ever work overnight or weekends, you will certainly have to take care of patients for intracranial hemorrhage because of their taking Coumadin. The treatment for this bleeding would be to reverse the warfarin. This can be done by giving vitamin K, anywhere between 1 to 5 milligrams, and it can be given sub-Q, IV, or IM. And this will improve the prothrombin time, or the INR, within about 6 to 8 hours. And that's pretty slow. That's not going to work in the case of emergency surgery. The books remind us not to give vitamin K IV, although we all do it, but perhaps it should be done slowly because patients can have allergic reaction or other side effects. A faster way to reverse warfarin would be to give FFP. And this is a fairly large volume. It's up to 15 milliliters per kilogram. So if you think about a 100 kilogram patient, that's 1.5 liters of FFP that you're going to be running in. Other possible treatments, and we'll discuss these later, would be prothrombin complex concentrates or recombinant factor 7A. And we'll discuss those substances a little bit later on. Now, unlike heparin, warfarin crosses the placenta, and it is teratogenic. It can cause damage to the central nervous system of the developing fetus. Of course, it can cause bleeding and other developmental defects. So this drug is contraindicated in pregnant patients or women of childbearing age who are likely to become pregnant. Warfarin is metabolized by a subset of the cytochrome P450 family, and as a result, we expect there to be interaction with many other drugs. Some of the most common drugs include antibiotics, barbiturates, phenytoin, and proton pump inhibitors. And there is variability amongst different patients as far as genetic polymorphisms. When warfarin is metabolized, its metabolites are inactive and they are excreted mostly in bile and in urine. So taking any of those medications will change a patient's metabolism of warfarin. 2 different patients may have very different effects from the same dose of warfarin. And then even changes in your dietary vitamin K will change the clinical effect of warfarin. So how do we know how much warfarin to dose patients? Usually we have to measure the prothrombin time, or the INR, with a target INR of 2 to 3, assuming that normal is somewhere around the range of 1. Warfarin is also 97% protein bound, so that's another factor that can make warfarin levels change unexpectedly. We're pausing here for a moment in case you have any questions you want to jot down, and then we'll move on to the next section. The next thing we want to talk about in the realm of anticoagulants are the thrombolytic drugs. These are what people call the Clotbusters, drugs that can be given to treat a case where there is a clot in a specific place that needs to be taken away. And drugs along these lines include Streptokinase, Alteplase, which is also known as tissue Plasminogen Activator, or TPA. The idea is that in your body you have a substance called plasminogen. It is activated to make plasmin, and plasmin is a substance that destroys clots. And a lot of these Clotbusters are drugs that activate plasminogen. They can be given IV in the systemic route, and when that happens, there is, of course, risk of spontaneous bleeding, especially in the brain. So this would be especially contraindicated in patients who have had recent surgery or trauma. And commonly you'll see this done in patients who are having a heart attack, an acute coronary syndrome, or a stroke. And usually this happens in more remote hospitals where they don't have high-tech endovascular techniques to address a clot in a more localized fashion. Now these drugs are also injected sometimes into a clogged vascular access device, like a dialysis catheter or a PICC line, in order to act kind of like some medical grade Drano and open up the catheter that's become clotted off. In some cases, an interventional radiologist or a neuroangio procedure can guide a catheter right up to the clot that is in a blood vessel and administer a small amount of one of these drugs right onto the clot in order to disintegrate it. The next group of drugs we want to discuss are the antiplatelet drugs. And we'll start with aspirin, which we've discussed just a couple weeks ago. Aspirin is an NSAID. It inhibits COX-1 and COX-2. And on the COX-1 side, we know that leads to irreversible prevention of platelet aggregation. So it prevents platelets from clumping and functioning the way they're supposed to. And patients take aspirin to prevent stroke, myocardial infarction, occlusion of coronary stents. And we have to decide what to do with patients who are taking aspirin when they come for surgery. Now, we're not going to go through all of the cardiology guidelines here, but just to remind you that in high-risk patients, so patients who have a coronary stent or have severe coronary or neurovascular disease, these patients really should continue aspirin throughout the perioperative period. And the only exceptions would be patients having surgery where bleeding would be catastrophic. Usually we're talking about closed spaces like the brain, the spine, or the posterior eye. And in those cases, the aspirin should really be out of the system, meaning stopping at least 5 to 7 days before surgery. And sometimes a risk-benefit analysis needs to be done in conjunction with the patient's neurologist or cardiologist, their surgeon, and the anesthesia team. The other common class of antiplatelet drugs are the ADP receptor inhibitors. And this, usually you think about Plavix when we're talking about these drugs. Plavix is clopidogrel. Other names you may hear are ticlodipine, which is Ticlid, prasugrel, which is Effient, and ticagrelor, which is Brilinta. All of these drugs are irreversible platelet inhibitors, just like aspirin, except ticagrelor, which is reversible. And they are given to patients to prevent occlusion of coronary stents. And together with aspirin, they have a synergistic effect. So all of these drugs need to be stopped 5 to 10 days prior to surgery. And while maintaining patients on aspirin is recommended in the perioperative period, there are few surgeons who are comfortable operating on a patient who's taking Plavix or another drug from that family. We should also remember that regional anesthesia will be contraindicated in patients who are currently taking these antiplatelet drugs. And in an emergency case where a patient is therapeutic on their Plavix, you may want to consider administering a platelet transfusion or doing some test to investigate platelet function in order to determine that the bleeding risk has been decreased. The main side effect, of course, from these drugs is bleeding. I'm going to stop the recording here. If you have questions, please get in touch with me or bring your questions to class, and we'll continue with the next video with the rest of the material.